So today we have Dr. Alan Kantrowitz with us today. He is currently the chief of neurosurgery at the Mount Sinai Medical Center here in Miami Beach. And just a little bio. I'm going to make it very short because I really want to get into the mindset of Dr. Kantrowitz. Dr. Kantrowitz is a graduate of MIT. He received his medical degree at the University of Michigan in Ann Arbor. And then he completed his training in neurosurgery at Mount Sinai Medical Center in New York, one of the pioneering centers for microneurosurgery of the brain, pituitary gland, orbit, and spine. Dr. Kantrowitz then was named neurosurgical director of the New York Center for Cranial-Based Surgery at Montefiore Medical Center in New York. Board-certified neurosurgery, Dr. Kantrowitz also holds several U.S. patents for developing medical devices for minimally invasive neurosurgery, image-guided neurosurgery, and other specialties. Dr. Kantrowitz is currently the chief of neurosurgery. He's a colleague, a friend, a mentor, and somebody who I look up to. We've been together for 20 years at the same hospital, and we're both on call today. So you're having two doctors that are taking their time to educate all of us about mindset and a healthy mindset. And I want to thank Dr. Kantrowitz for being here. I appreciate it. It wasn't very easy. I had to pull you from the ICU.
Fine.
So Dr. Kantrowitz, or I'm going to call you Alan because we're good friends. Take me just a little through what it's like to be a neurosurgeon, and let's get into just right off the bat. Is what is it like cutting open a brain? Like what is it like? I mean, is it something that you dreamed about in the beginning of a certain age, or how did you get there? How did you first get into knowing that you were going to be a neurosurgeon?
My particular pathway was unusual. I, as a young surgeon in training, looked at all of the different surgical subspecialties, and I looked at orthopedic surgery, which was just beginning to really expand at that particular historical period of time. I looked at general surgery, heart surgery, and of all of those fields, I felt that the one that had the largest future growth potential in terms of increasing the breadth and depth of the science was neurosurgery. All of the other fields I felt were much more fully developed. And I thought that a field that had a much broader range of possibilities was a better fit for my particular frame of mind and how I wanted to make my contribution to the betterment of mankind, literally. And so I looked very closely at several of the other surgical subspecialties, and I found them not as compelling a draw to me as neurosurgery. So then, why neurosurgery?
So why neurosurgery? Why all of a sudden, let's say you wanted to do neurosurgery as opposed to a different path? Because you have a family, right? A family of doctors, right?
There was certainly a lot of discussion around the dining room table about all of these different kinds of issues. But for me, just approaching medicine as a field within biology, as a larger subject, neuroscience was really had the deepest mysteries and had the most profound implications about who we are as human beings and as individuals. And I found that a more interesting place to start thinking about what it means to be a human being. My interests in neurosurgery have always been multi-layered. The technical, geometric, sculptural aspects of entering into surgical procedures is one dimension of it, but what's actually much more compelling to me and to you as a neurologist is thinking about the brain as being the physical substrate of our being, our spirit, our humanity. And that's an amazing set of ideas to contemplate. And anyone who is standing on the edge of that particular chasm can't help but be stunned by the mysteries and the complexities of the human brain.
So talk to us about, people don't know how you get to the brain. So how does it work? Oh, do you use it? How does it work?
The way, the process, of course, doesn't begin with the operation. The process begins with talking to people, understanding what their fears are, what they are concerned about, and what has been happening to them. You are my teacher when it comes to the art of interviewing patients about their neurologic condition and how has it changed over time, how it's affected their individual body and their interrelationships with all the people that are important to them. You are my teacher about those kinds of interviewing techniques, styles, and goals. But that is where I actually begin. And like you, I always try and come up with an understanding of what is going wrong inside a patient's body in order to explain their history and the progression of their symptoms and their progression of whatever their physical findings are. And like you, and actually modeled after your kinds of intellectual techniques, I try and arrive at my understanding three-dimensionally in my mind of what I think is going on inside that patient's body, which would produce that history and that set of physical findings and that set of laboratory findings. And that you and I call that our working diagnosis. And we always have a differential diagnosis. We may order them. We may assign different possibilities. The situation may be so obvious that the number one item on our differential diagnosis has an odds of 99.9%, and all of the other odds are diminished. Or it may be something much more even, and the job that you have and that I have and that we've accepted ownership of is trying to come up with a differential diagnosis. Having done that, that's when you and I start to walk along slightly different pathways. And what I am actually doing is once you and I come to some kind of a consensus that we think there is a structural, three-dimensional, architectural problem that is responsible for the patient's unhappiness, then the process that you and I will work through together is there an alternate three-dimensional structure, which if we could reshape the patient's anatomy into that alternate hypothetical future, would help the patient have a better life. And so in that sense, I consider my job is very similar to that of being an architect. My role is to imagine a new three-dimensional structure which would serve the patient well. And then I switch hats from being an architect to being a general contractor. And my next job is, which is I believe the question that you're getting at, is how do I go about doing that? And my job as a general contractor, in that sense, metaphorically, is I have to imagine a sequence of three-dimensional anatomies, which in a stepwise fashion, each step has to be safe and achievable. And if I can follow that set of steps of incremental changes in 3D anatomy, I can carry the patient from their starting malanatomy, if you will, or pathologic anatomy or dysfunctional anatomy, and rework it in the operating room so that there's now a happier anatomy. So that's a kind of an architectural and a construction metaphor. How do I actually go about doing this? As you'll notice that when I talk to you about the steps, I inserted the word achievable and safe. That's literally what I do. I have to visualize, when I'm thinking about a patient's problem, a way for me to get to where I have to go, and there has to be a safe route to do that. Most people imagine that I make a scalp incision, and then I make a bony opening, and then I make a dural opening, and then somehow I work my way to the target. That's not actually what happens. It's actually the reverse process. I start from the target that I must arrive at, the geometric target. From that target, I draw in my mind's three-dimensional eye safe routes for me to get from that target out to the surface. And that surface, by the way, can be the scalp. It can be the interior of the nose. It can be the interior of the mouth. It doesn't necessarily literally have to be through the top. We can come through the so-called base of the skull also, through the nose, or we can come from just above the eye. We can come through the ear. We have all kinds of ways that we can enter along one of those trajectories. And then having figured out now what is the preferred route in terms of brain safety and patient safety, and how I actually would achieve the goal that you and I would have agreed on, then I design a bone exposure and a scalp exposure that then allows me to now reverse that sequence of steps and now go from the outside to the target. So the operations, although they are explained from the outside in, they are designed from the inside out. And this is something that any experienced neurosurgeon can do. We can actually do this in seconds. We are trained. We know all of the available routes. We've thought about them. We've discussed them in training scenarios. We've discussed them in conferences, in training laboratories, and then during the training process. I want to return to the training process. There's something interesting that happened in 1965 about training neurosurgeons that you and I have never talked about. Typically when you and I discuss a case, or with any of my colleagues, any one of us, we will know the solution within 2 seconds because we are trained to do this literally. You might say automatically. I would ask you what's actually going on inside my brain when I'm doing it. But it is, once you understand the principles, it happens very, very quickly.
So that's part of what I talk about is habits, and habitually you are in autopilot a lot of times.
Oh, absolutely.
And you're in a flow state, and do you feel that at times your hands are working just on autopilot without being consciously aware while you're doing the surgery?
I wouldn't choose to describe it that way, but the best metaphor for what you and I would often refer to as motor memory, I would present the everyday experience that everyone has when they are typing. Most experienced typists, now that we're all on computer terminals seemingly around the clock, you're thinking of the word, you're not thinking of the individual keystrokes. Can you slow down and think of the individual keystrokes and hunt and peck? Yes. But most of the time, we have an idea in our mind of the words that we want to type, and they just flow through some mystery of the extrapyramidal system. I'll ask you to please explain that to me in a later podcast. But there's this process that is commonly referred to as motor memory, but really what's going on is that I've got a behavioral objective, and it is, in my mind, it is my extrapyramidal motor system and my what I refer to as complex sequenced motor commands, that the ideas literally just flow out. And what starts as a three-dimensional idea in my head just becomes a series of finger and wrist and arm motions.
Well, it's like driving a car and being able to get to that destination. And I think it's habitual, and I think it's done under the level of consciousness.
I agree with that.
And what's interesting, if you look at a keyboard, believe it or not, you can type on the keyboard, but if I ask myself to actually name the letters on the keyboard, I don't think I can.
Of course.
But my fingers could just go on and on and on, but I can only tell you Q, D, S, and from there, I can't really remember the exact keys. So let me ask you, because this is just for the normal audience, what is it to expose the brain? Are you using a drill? Like, how do you get there?
Okay, so.
Yes. We want to know how to get there.
The way
Yes.
we do this is, having gone through that inside-out process, I know how I have to make an incision in the scalp, or perhaps through the nose or through the mouth. I know what soft tissues I need to make an incision and peel away so that I can see the bone that I know that I must go through. I have a number of options on how I open the bone. I have a whole armamentarium in the operating room. We all do. But what all of these tools have in common is they allow us to deal with the tremendous difference in the mechanical strength of bone, which, after all, by nature and by natural selection has been developed to mechanically protect the incredibly delicate underlying structures of brain and spinal cord. So we have, in all of the locations, whether we're talking brain surgery or spine surgery, we have developed methods to remove these incredibly tough structures, but with superb control depth of bony removal. And I've got at least 8 or 9 different styles. I have various kinds of power drills, and I have various kinds of delicate dissecting instruments, but they all have in common is that they allow me to remove a small amount of bone with a very, very controlled risk of going too deep. So it is the challenge, the surgical challenge, the dexterity challenge is to cut bone without damaging exquisitely delicate tissues that might be only 1 millimeter deep to the bone, sometimes even less. And if it's even less, we even have a style where we literally take a diamond tool and polish away the bone, and we just keep polishing the same patch until we realize that we have just crossed the bone. And we can do this in any geometric pattern, and that's how we remove the bone.
So, repetition is so important because you're so experienced of doing this so long that you are, I think you go in autopilot. What senses do you feel are the most important? Is it auditory? Is it palpation, touch? What is the senses you think is like one of the most important part of neurosurgery that you experience, or what do you feel? So everyone has some type of sense. What is it? You're going in, obviously you're very visual, right?
It is extremely visual
Yes.
and extremely tactile. I am monitoring how much force. Of course, I couldn't put it in words, but it's
Right.
Certainly, you and I have talked many times about something I'm sure that you'll explain in some of your other talks about proprioception,
Sure.
Muscle tension, and how much the nervous system is spectacularly good at keeping track of how much force we're exerting on a tool, and we're keeping track of how much the surface that our tool is against is yielding. And that's how we measure. The mechanical engineers talk about the modulus of elasticity, And it is not unusual for us to be exquisitely aware when we're going through the layers of bone to very, very rapidly recognize when we no longer have bone of the same strength. We even can recognize when there's only an eggshell of bone left and we're about to break through. And again, this is built in. The neurosurgeons have this skill, and there is a very interesting and beautifully trained group of ear surgeons who have developed to a very, very high art, the art of working their way through the bones behind the ear, this part we call the mastoid, and work their way. If they keep going, they can get to all kinds of neural structures there. And I have been involved with many operations where I stand in awe of the dexterity of the neuro-otologists. It's an honor sometimes to be operating with them.
What does the brain feel like? People want to know, what does the brain feel like?
So what we can do, the first thing that we do when we expose the brain, so we've worked our way through the scalp, through the bone, we have to open, there is a layer of living tissue immediately coating the inside surface of the bone that we call dura. You and I talk about it literally every day. There are many, all kinds of medical conditions that affect just the dura alone, and that evolves. But for purposes of this discussion, it is possible to make an incision in dura, reflect the flaps, and at the very end of surgery, we can sew that flap together and reconstruct the dural layer. But having reflected the dura, we are then looking at the surface of the brain. And what we do is, first of all, we usually pause and watch. There is one scenario where we don't have time to do that, and if we can talk about that one unusual scenario. But if you want to know what I do 5 days a week, is I will, after I open the dura, I watch the surface of the brain, and I'm looking for a couple of things. And by the way, I am looking either with my unaided eye, or I am looking with what are called magnification loops. People have seen in the movies and such, the Watchmen with their single monocle. There are more sophisticated and elegant loops that are mounted on a kind of a highly modified eyeglass frame that has all kinds of adjustments on it so that you're looking right down the axis. And when I choose to, I can swing in a fully counterbalanced, cantilevered operating microscope. It's an optical device. It probably weighs 50 to 60 pounds. It has scientific grade optical glass in it. And it is being suspended from a counterbalanced arm so that it is weightless. And the devices that we use nowadays have electromagnetic brakes on every joint. And so I can choose between having it float effortlessly, or I can take my finger off a switch and all of the brakes lock. So at that point, I am looking at the surface of the brain. And what am I looking for?
Sure.
The first thing that I observe is the pulsatility of the surface of the brain. Every blood vessel in the brain, both the arteries and the veins, already have a pulse on them. The arteries have an arterial pulse that is derived from the heart, from the left ventricle, and the veins have a distinct pulse waveform that is being imparted to them from the right atrium up the vena cava, up the jugular veins, and from there throughout the brain. So the arteries are jumping with every heartbeat. The veins are jumping, but also shifting with every breath that the patient takes. And the surface of the brain is jumping with a pattern that is the summation of those two patterns. The so that is the first thing that I watch. I watch the pulsatility, and I also look for regional differences in the pulsatility of the brain surface, because that is telling me what's going on deeper that I can't see. So if, for example, you and I have had many patients we've shared care together where there is a stiff brain tumor, so-called mechanically stiff, meaning stiffer than brain, and I can appreciate local differences in the pulsatility of the surface of the brain, and that helps me decide exactly how I'm going to make my next move. And there will be times when the surface of the brain stops, is much less pulsatile in some area. That also, it's helping me understand mechanically what's going on there. So I'm looking at the pulsatility. I am also looking to see how the surface of the brain varies with each respiration. I can hear the anesthesiologist machine breathe in and out for the patient, and I watch that. The next thing that I look for is unusual local variations in the vascularity of those small blood vessels that actually come to the surface. You and I have had many patients that we've cared for together where we know they have a disease process that has a much richer blood supply than it needs. And so the arterial supply into that disease process, much of it will pass right through the disease into the veins that are draining that disease and will raise the oxygen content of the veins draining an area. So I am looking very carefully with a $600,000 operating microscope for subtle variations in the color of the venous blood draining different gyri. I'm sure in your other conversations you've talked about these hills and valleys that are on the surface of the brain. So that's the next thing that I look for. I look for arterial, what you and I would refer to in our technical conferences when we talk about patients, for shunt, so-called AV shunting, or what can also be described as arterialized veins.
Okay.
And really what it's telling you is somewhere in the part of the brain that is being drained by that vein is a disease that has demanded more arterial blood supply than the tissues in that area can actually consume. And the extra oxygen passes right through and changes the color of the vein. So that's me being a bloodhound. I used to be an architect and a general contractor. Now I'm a bloodhound. I am looking for veins that are redder than they ought to be. Okay? And I take all of that information. I also, in this day and age, of course, we have all of these computerized systems that are taking our CTs and our MRIs, and they are what you young folks call augmented reality display systems. We actually can display the underlying CTs and MRIs that you and I might have talked about in our multidisciplinary conference, and we can overlay them directly on the surface of the brain. And so I can use that information also. And I'm doing all of this to decide how do I get to the disease process. If I have an opportunity to exploit a naturally occurring channel, you and I talk all the time about sulci and basal cisterns and so on. Modern neurosurgery, which again dates to 1964 and the invention of the introduction of these kinds of microscopes, modern neurosurgeons are always looking for opportunities to get to their target, even if it isn't a straight line. But if we can exploit a pre-existing natural channel to get to where the problem is, we will do that. One of the secrets that happened in the mid 60s, the introduction of the microscope, was that there was also the introduction of a style of using handheld instruments. And that was done by my mentor. And so when you talk about Mount Sinai Hospital in New York in the 60s, what you're really talking about is that was the place, one of 3 places in the world that people started using these styles of surgery. And basically, we look for these opportunities to get to a deeper target. And what we're trying to do is either avoid completely the need to make an incision in the brain tissue, or perhaps so minimize it that it does not hurt the patient.
So I think you just summarized neurosurgery. I think by just listening to you, I think you could complete a residency. That was very detailed. Amazing. So, all right, so let's get into, that was very, very structural, very good. So
you asked me what's actually going on inside my head.
So
that's what's going on inside my head.
If you learn anything about Dr. Kantrowitz, he's a well-experienced neurosurgeon, and all of these things that are going on in his head, believe it or not, how long does it take you to go through all of that?
You mean to learn how to do this?
Not learn how to do it, but through repetition and from all the cases to go through all of those step by step by step, how long does it take you?
I'm not sure of the question. Are you asking me how did I learn how to do this, or when I'm doing it?
When you're doing it and you're in the flow state and you get to a patient and you're in your mind, you're going through all the check boxes because it seems like you go through the same habitual patterns and behaviors and
this happens in 2 seconds.
In 2 seconds.
This is as natural to me as breathing is to you.
So that's
it
what
happens like this.
It's amazing. Amazing.
It happens like this.
So it shows you how complicated our brain structures are.
You and I have had many conversations.
So the most amazing thing, Dr. Kantrowitz, is that I asked you about cutting brain, and then you went back and talked about the patient because I know who you are, and I know what kind of physician you are. And when I treat patients, I obviously send them to you. I think the best patients are when a patient comes in and we can localize the patient's symptoms. So as a neurologist, we're always localizing where in the brain or the spinal cord or wherever in the nervous system it is. So if it is structural, then you and
I will have a dialogue.
You and I have a dialogue. The thing is, what I've watched you do is you give your cell phone out. You have patients call you directly. You give them a sense of safety and security, and patients are fearful. They're scared. They're afraid of surgery. They have a condition that requires surgery. At times, it's emergency. We're both on call. You can be called any minute to perform an emergency surgery.
In the middle of this podcast, we might have to interrupt it. We're watching my phone and your phone right there.
Right. So we're on that sense of where we have to jump and do things right away. Just take us back with being what is it to be like a doctor that's a surgeon? Because surgeons get a rap. They get a rap that they're just there to take things out and they're mechanical. And what makes you different than any other neurosurgeon as a physician, as a human, as someone who has empathy?
I can tell you what I strive for. Whether I achieve it or not, you'll have to ask the patients. The first thing I do is I don't wear a white coat. I do not have a white coat. I try very, very hard to remove what I would call separation barriers. So for those of my children who are trying to educate me about linguistics and brain science, they have a word, iconicity. And I think it means, for me, it means the meaning imparted by a visual object or characteristic. So I believe personally that my real job isn't doing operations, that my real job is reducing fear. Sometimes the way to reduce fear is to carry a patient and a family through a long, worrisome craniotomy. Sometimes the way to reduce fear is simply just to be there and let somebody know that they're not alone. And anything in between. I absolutely try very, very hard to eliminate barriers to being in the same place. Those barriers consist of several different tools that many surgeons use to keep boundaries. One is the damn white coat. Two is technical jargon. I could tell a patient, well, I'm going to do a, right frontal pterional exposure, and I'm going to dissect along your sphenoid wing, and I can start naming all of this technical stuff. But it's really just jargon. And it is, in most surgeons who use this kind of technique in trying to communicate with their patients, I believe, personally, this is my personal opinion, this is, I think they are using it so they can reassure themselves and the patient and the family that they've had time with surgeon. But I don't believe the real goal is to achieve mutual understanding. I believe they throw out the jargon and walk out of the room and say, there, I told you what you need to know about your diagnosis. In the meantime, someone who is scared because they just been told they need to see a neurosurgeon, and then here's this neurosurgeon, really what's going on inside their head is, oh my God, oh my God, oh my God, oh my God, is my life over? What's going to happen to my spouse? What's going to happen to my children? And that's all that's rattling around inside their head. And they're not hearing any of this stuff anyway. So I think it's nonsense to believe that just because you've thrown, 75 technically correct jargon terms at them, that you have somehow helped them at the level of understanding. And then the idea of giving a phone number is my way of saying, I know that this is really scary, and I don't want the complexities of answering services and call centers and layers of protection to be a barrier to knowing that there's somebody out there who cares. I think the bravest person is not the surgeon. The bravest person is the patient.
Beautiful. Well said. So to me, I believe, and we've gone through this conference, and is two things that I think are important. Is one is listening, empathizing, understanding the patients, and then taking those symptoms, making a diagnosis, and then correlating it with a structural anatomy. Because when we know that that structure is correlating with the patient's symptoms, I see that the outcome is going to be hopefully favorable, plus obviously the surgeon that they go to. Those are the two biggest things I see. That's why I protect my patients from the surgeons, because I want to make sure that my patient needs surgery because it explains the symptoms. Because you and I have gone through this, where we see not only does Dr. Kantrowitz operate on the brain, we talk about back pain and neck pain and numbness and tingling and symptoms we can't explain. And then you see a disc herniation, and that disc herniation doesn't correlate with the patient's symptoms. You bring the patient to me and say, look, does the exam, does the history, does the testing, does all of the symptoms correlate with that finding? Because in my experience, a lot of surgery is done for the wrong reasons. And I feel that patients, once they go through the knife and they had a surgery that does not explain their anatomical site, then they can develop now complications related to the initial surgery. And we're not sure now, is the patient's symptoms related to the first surgery, or is it related to an underlying psychological condition or neurological, what I call a sympathetic nervous system that's on overdrive. So I feel that as a neurologist, it's so important to listen and understand the patients, because surgeons don't act like you do. I mean, that's why you and I have been talking about this. This is why you and I have created a multidisciplinary conference where neurologists, neurosurgeons, what we call neuroendovascular specialists, neuroradiologists, the surgical ICU team, the MICU team, all of these multidisciplinary approach to the patient. So every single day we talk about every single patient. We go through all of the different avenues, because the way I look at a patient is very different the way you look at a patient.
Right.
And, I have definitely realized that you and I started the conference, how many years ago? It's got to be 10
years ago.
10 years ago. We've diminished the amount of complications, and we've also limited the amount of testing that needs to be done. And we've noticed that our outcomes have been extremely favorable. So let me get into life. Like, what, a neurosurgeon. Okay, let's first talk about, because people really don't understand. We talked about structurally how your brain works when you perform a surgery. How long is this roughly? I mean, we could talk about surgery from minutes, not minutes, obviously, hours to several hours. What people want to know, because I've seen it. I've seen you in the OR. How long? What is your longest case you've ever been at?
29 hours.
29 hours. Mm-hmm. And what was that?
This was in that particular case. It was 30 years ago. I remember the patient. I remember the lesion. I could draw you diagrams of what the problem was and how we went about solving it. That was a very large skull-based tumor called a clivus chordoma. And I organized a team of oral surgeons to help me make that. Remember earlier when I was talking about sometimes we have to remove bone, and we had the ability to go either through the nose or through the mouth or anything like that. We can do that. That particular case, I had organized a team of 6 surgeons, each with slightly different areas of expertise, and we worked together and we solved that problem. We just kept each other going. So 29. I've also done,
let me ask you, because we understand the hours. Like, so how do you stand? How do you go to the bathroom? How do you take breaks? Explain to me what goes on in 29 hours. People want to know, how is it possible?
There are 2 cases.
Yeah.
There are 2 cases. One when I'm doing this by myself, and one when I'm doing it with a team. When I'm doing it with a team, I have handpicked and built the team, so that I know that if the mouth guys are doing their thing, that takes pressure off me, and I can scrub out for a few minutes, and that's fine. I once had to do a 26-hour case by myself because I had no one available to me who was capable of joining that team. I still remember the patient. Now I'm remembering her husband and her daughter. And it was a hell of an experience. And I did have to do a 26-hour operation by myself. The only thing I had to do was to take one short break with I had a good, competent helper, and I put a break in the operation, and I had to go and take care of my own needs for a few minutes, and then finish the 26-hour thing, which I did. And that can be done, and it is done. I suppose it's the same thing as these special ops guys who are doing some military operation, and it's, when you're in the heat of the battle, you just draw on your internal resources.
So let me ask you, how do you clear, this is I've never even asked you these questions, and there's 2 questions. There's one, how do you clear your mind to be so focused for surgery? How do you really get into that flow state? And then the second is, what kind of music you listen to.
The flow state is easy. The flow state, it is so automatic. I don't quite understand all the neurophysiology of my mind when I am operating like this, but I can tell you that I have no appreciation. My wife can also tell you that I have no appreciation for how much time is passing. Her standard formula is whatever my estimate is she triples it and adds 5 in whatever units I'm using. No, it's whatever this automatic state is. You might want to call it habit. I'm familiar with this term flow from the athletic literature, but what's actually going on is I'm just extremely focused on making sure that what's going on inside my head is literally, it comes out through my fingertips in terms of fingertip movements.
I mean, the way you described everything, and you told me that in 2 seconds everything goes through it, through repetition, and from your experience, it is no question your subconscious is just running, and your brain will alert it when there's something that is an error detection.
So that is a very interesting question. I call that the self-monitoring function. It is extremely important. When I try and describe that, you're the first person to ever ask me about that, but I'm very much aware that even as I'm doing this, there's another part of me that is making sure that things are going the way I expect.
Exactly.
It is extremely important that whatever my starting assumptions are, when I am presented with new information, I have to be prepared to abandon my interpretation of the films, the whole thing. In common everyday parlance, you might say sometimes when you get stuck in a rut, you just got to get out, toe out, and start into a new pathway, whatever metaphor you want to use. But I call that the supervisory. And the failure to do that is how people can really make a bad situation unsalvageable. What I try and teach other surgeons how to do is how I'm always having a concept of where I expect the case to be at this point, because I guess I've pre-visualized the whole thing. And whenever it starts to deviate from that, I stop. Sometimes I will step back and even take my gloves and sterile gown off and go back and look at the films again. And I'm actually doing a couple of things at the same time, but what I'm really doing, what I would share with you and with your audience, is I'm really giving myself an opportunity to reboot my thinking.
Exactly. I was calling it resetting.
You were calling it resetting.
Yeah.
I call it rebooting. I'm calling it giving myself an opportunity to scrutinize which of my starting assumptions are now being contradicted or countermanded by new information as the surgery evolves, or to put it in program parlance, as the project evolves.
I have principles that we talk about, which is one of them survival and protection. The other one's efficiency, and that we use habits. And the thing is that when you're in that, your brain, is burning 20% fuel, and you need to keep that brain in a very efficient environment, working with your hands and just really an autopilot. And then when you're critically thinking, where you now have to move out of that zone, that's where you hit reboot, reset, and that's where you use your energy. That's the key, is to use your energy appropriately. Now, you didn't answer the second question, was music. What kind of music? I want to know what music.
I do a couple of things with music in my OR. I actually use it as a tool to keep the rest of my team calm. As you and I have now been talking about for a little bit of time now, I am completely engaged. But not everyone in my room is as engaged as I am, because I'm the guy in the hot seat there that's actually doing this thing. I need to keep everyone refreshed. And what I typically do is I go around my team room and give people an opportunity to pick the next music. That keeps them involved. That keeps them engaged. And that is a trick that I use to make sure that everyone on my team is fresh and is focused on what is going on.
It's like pressing the jukes box.
You pick the next one, you pick the next one, you pick the next one. I actually call it conducting the orchestra from the piano.
That's a great, I like that. I do like that. Has any patient experienced where they either woke up from surgery or they're able to tell you that they heard a certain song or music?
No, that's never happened to me that I'm aware of. I have been forbidden by my anesthesiologist to play one particular song when a patient is waking up.
Okay. We have to share that.
And let me just remember the movement. It's Rachmaninoff, Vespers.
Uh-huh.
It's a particular movement. I think it's the first movement. And it is so exquisitely beautiful that my anesthesiologists have said, Alan, when the patient is waking up, they're not going to know if they're in heaven or not. So you cannot play this when they're in that twilight zone, when they're waking up. It's got to be something really with some edge to it. So we pick something with some edge to it.
So we're talking about your mindset, and you already told me a lot of the habitual behaviors and the things you do. So how about fear? Do you have fear?
Absolutely. I am very aware of all of the things that can go wrong, and I'm also aware that there can be other things that I haven't even anticipated. To quote Donald Rumsfeld, we have the known knowns, the known unknowns, and then there's always the ones that we really worry about, the unknown unknowns. Twice in my career, I have had one of my team members have a medical emergency in the middle of surgery that I'm performing. Twice in almost 40 years. So that tells you the incidence, operating almost every day. You can do the math. So occasionally it happens. And then we immediately redeploy the human resources that we have available and split into two teams. And I will take care of my patient, and I'll have one anesthesiologist help me with my case, and I'll take one nurse and say, you're sticking with me, and the other people, even while we're summoning more help into the OR. It's happened twice to me.
So how about just very briefly, we don't want to get to specifics, but what are the zones that you look at when you're taking out, let's say, a tumor or operating? What are the no-no zones that could cause significant neurological impairment? What are you looking at in the brain itself?
You and I use a phrase when we're talking professionally about eloquent brain and non-eloquent brain, but you and I recognize that when we use the phrase non-eloquent, that's shorthand for we haven't figured out what that part of the brain does yet.
See, and that's so important. Isn't it amazing how a neurosurgeon and neurologist, we can talk about parts of the brain that we still don't know the function of it. The eloquent part, though, explain to the audience as far as what do you mean by eloquent? Language center?
Eloquent means if there is dysfunction in those areas, you and I can predict what the patient's neurologic problem will be. So if it's in the so-called arm control area, you and I will recognize, either because that's where the disease process is or the treatment somehow affects that spot. You and I are, we've usually warned the patient that we expect that they may have some difficulty with an arm or a leg or the corner of their face, what have you, or language, or coordination, or a particular limb. I mean, there are areas where we can predict. Usually you and I are already aware that the patient's disease process is near those areas, because that's how we learned about their problem in the phase when you and I are interviewing them and examining them and getting the neuro studies. So in this day and age, these are rarely surprises. in the so-called bad old days, which really dates to before the operating microscope in 64, 65, before this CAT scan, which was late 70s, 79, 78, somewhere in that time frame. I'm sure somebody listening to this will get the exact date when Professor Hounsfield first introduced the CAT scan, or the MRI, which was already starting to be used clinically by 83, 84, and again, someone in your audience will fine-tune these dates. Those before that are the bad old days.
Now, okay, so let's move on a little bit. So I want to get into your life because people don't know what it takes. They can see now how dedicated you are in the OR around patients, and what's it like to be a neurosurgeon? Like, what's your lifestyle like? So, I mean, you've done this for quite a while, and we have definitely different lives. I'm a neurologist in neurosurgery, but we do work very hard, and we've dedicated ourselves as being spouses and a parent. And what is it like to be a neurosurgeon? Just discuss maybe the things that you had to give up, things that looking back, you might have wanted to spend more time maybe with family, or is there anything that you regret, or are you saying this is what I'm proud of and I'm content? And what is it like as far as in your stage right now, looking at yourself and seeing how much you had to give up for our patients?
I think the difficulty with the kind of engagement that I'm talking about, illustrated by my giving the phone number to people, means I have done a really, by design, I have tried to lower the barriers between my patients and me. That has been very, very costly to the people in my personal life who I love and who love me. It is an enormous price, you'd have to interview my children to understand. I think that I would simply summarize that whole part of me and my life as neurosurgery and the way I approach it. And you and I recognize there are other ways of approaching neurosurgery with more strongly reinforced boundaries between me and my patient and me and my colleagues. In my case, I have, and my children have paid an enormous price for this. Some of this came about, you had, in the introduction, you had alluded to my upbringing as a child. And I was brought up with a father who was utterly and totally committed as a physician and as a creative physician, inventing new treatments, to doing that. And some people might have described that as having been corrosive of my relationship with my father. But I never viewed it that way. I always viewed it as Daddy was doing something incredibly important, and the time that I did have with him was very meaningful. But the way to try and explain my childhood to you and to your audience, the joke that I make inside the family is based on the idea that my mother decided that she was going to take me to Yankee Stadium because my father never did. And so she took me once up to the bleachers in Yankee Stadium. I sat in left field. And then after that, I was 8 or 9 years old. I could take the subway from Brooklyn to the Bronx. I was very comfortable doing that. And in those days, it was a very easy thing to do. So I would make my own way to Yankee Stadium. And yet it was my father who taught me how to sew, but he actually taught me how to suture. So there I am in the 3rd grade, and my mother took me to my first baseball game, and my father taught me how to sew. The joke being, of course, that sewing was not trivial sewing. It was the real deal. And going to Yankee Stadium, I just needed to learn the subway route once, and I was doing it myself anyway.
And so I just finished talking about how we download our programs from third trimester to 7, and that sewing was downloaded program. That shows you that our subconscious knows what's known, familiar, comfortable, and believe it or not, that was very comfortable for you. And believe it or not, this is a question whether we have agency or things are determined. And
correct.
Were you determined to be a surgeon? Was I determined
to be a surgeon? So I'll tell you, because that is something I have discussed with my kids. I think there was one other formative experience that I would bring up in this kind of a conversation. When we lived in Brooklyn, we lived in a very old house. It was 100 years old. There was something that had to be fixed every weekend, and in lieu of going to baseball games, what my father and I would do would be to fix something together. And he had his toolbox, and I, as a little boy, I had my little boy toolbox, and we would go around this big old rambling house, and something had to be fixed every Saturday. And
you had the drills, I'm sure.
And I had my little kitty tools. But I did have my little kitty toolbox. I remember it quite well. But the point is, it wasn't actually surgery. It was actually three-dimensional visualization skills. And that is something, whether I was programmed to do this or it's something that comes very easily to me. That is a question I would ask of you, but I do have a very highly developed three-dimensional visualization skill, which I can see in my kids. I don't know what that's all about. That's a question for you.
Well, that's all about is that usually we develop these skills when we're so young, and that's something, you're somebody who visualizes. You probably have a very good, very strong imagination.
Three-dimensional.
And three-dimensional. Absolutely.
Yeah. No, I always am visualizing things in space. I'm not so good with words. And I did terribly in reading and literature and those kinds of things. I never understood what that was all about.
And it tells you, like, we have kids, and our kids are told that they need to be good at math, they need to be good at English, they need to be good at history. And you're at the top of the game of being a neurosurgeon, and let's say your words weren't, or English maybe wasn't the strongest category, but your visualization took you to that level of success, correct?
I could absolutely professionalize my three-dimensional understanding.
That's amazing.
The way a sculptor might, the way an architect might, the way a builder might. I mean, there are other professions that use engineers. There are people who have this kind of way of looking at the world.
So moving forward, we're going to hopefully wrap this up, but moving forward, let me ask you, so there's a new generation of doctors, and your training and my training, and the whole idea of a neurologist is a lot of thinking, critical thinking, localizing, really getting into detailed history examinations. And we're seeing a new wave of, in general, I don't want to badmouth doctors. We are becoming more reliant on the phone, AI, making diagnoses, replacing some of our critical thinking. As a neurologist, we're going to move that because this is about neurosurgery. What are you seeing? A different mindset, a different tool set? Are you seeing something different in the new wave of surgeons? We don't want to say neurosurgeons or surgeons on the way they approach patients.
Not yet, but remember, all the people who are even young surgeons now are, if you look at the calendar, They are not of the current iPhone generation that we're talking about. Their mind patterns or their cognitive habits or whatever you want to describe them as were probably laid down before the iPhone. The real challenge is going to be 15 years from now. What I would remark on is the flatness of the screen as opposed to the three-dimensional nature of the imagination and visualization. I said before that I was really good in school at problems which required a three-dimensional visualization of the problem, and then I was home free. I can solve. But if the problem is only recognizable and understandable in a flat planar arrangement of symbols on, for many years, 8,000 years, pieces of paper or cuneiform tablets, or more recently, flat computer screens, then that's a different thing. And I would point out to you and to your audience the difference between the written transcript of a congressional debate on a social topic as opposed to what was actually going on the congressional floor when members of our decision-making government were talking, physically interacting, having alterations in their facial tone, their facial structure, their tone of voice, their body language. There are many, many more dimensions to what is going on between several individuals or two individuals in direct face-to-face communication. When you reduce it to something flat, two important things are lost. Number one, instead of playing out over time, it gets expressed as a single moment in time, the moment that those symbols were captured on that flat media, whether it's paper or computer screen or what have you, were projected onto the inside of some sphere in Las Vegas, whatever it is. But it is frozen in time. Mm-hmm. It's not varying in time. Mm-hmm. You and I can have an in-depth conversation about hearing, music, locomotion, all of which are playing out over time. And even you and I could have a conversation about real-world visual experiences when we were in the forest trying to run away from bears, sure, or whatever our ancestors 50,000 years ago were trying to do. There is a temporal access to the information which is incredibly rich, and it's all being lost in these flat media.
Right, because our consciousness is a collection of our senses into an experience. And if you don't have those senses, specifically on a screen or a telemedicine, you lose that. And also you lose our subconscious nonverbal connection and behavior, feeling safe and secure, and tactile touch. And all of these things are so important in our brain.
We evolved in a three-dimensional, challenging environment.
Well, I just finished a podcast and I just talked about how we're developing a new brain. And this new brain, like you said, we're going to start seeing it. We're in it now, but we're going to start really seeing it in probably 10 to 15 years from now. One of the things that I admire about you, there's a lot of things, is that you're very humble. And we spend mornings together. We have a conference. And the most amazing thing that you do, because you got a bunch of doctors, neurosurgeons, neurologists that have their opinions, and they will always want to be right, and that we debate, and we want to be right, and we want to be right. You ask this question, and you say, can you explain that to me? I've never heard of that before, because sometimes we want to swallow our pride, and you use terminology that I've never heard of, especially in neurosurgical techniques. What is it makes you so different that when you say, I don't know, or explain it to me, you're the only doctor that I've seen do that in a public setting, saying, you know what, I really don't know. Have you ever realized that?
I am aware of it.
Yeah.
It's actually a gift from my parents. Mm-hmm. the father who taught me to sew and the mother who took me to my first baseball game. It is the gift that I don't define myself as being the guy who's right. I define myself, I think, as someone who's trying to understand the connections between different things. And once again, there's that three-dimensional visualization stuff. You can see it in my hand gestures. So if I can't connect the ideas, that's where I go, and I have no problem because it doesn't undermine my sense of who I am and what I am. Those are gifts from my parents.
Yeah, because that's a gift, because I can tell you when we go around and when I don't know, it shows that you're humble, because when you speak and when you talk about your experiences, you're very well respected. And I think that makes you very human, makes you very approachable. And it really allows me to do the same, because in the mornings when we have to get through our rounds and all of that, I crave learning. I crave it. It's one of those things I'm addicted to. There's a reason why I'm doing this podcast, is to get my point across. And I would like to teach people how to be human, how to be like, I don't know, how to say, I don't know, and make mistakes and be okay with it and learn from your mistakes.
Yeah, but I also have a very explicit team building goal in mind. You and I have talked about this before, so you can anticipate the point I'm about to make, which is that the reason you and I have developed this multidisciplinary huddle is fundamentally to improve patient safety. That's the goal of the process. But the technique for doing it is to grant authority of everyone on the team who makes an observation and give them permission to speak up. And so in my mind, what you and I are doing there is we are actually creating an organic process that has many more eyes and ears on each patient than just mine or yours. The origin of all of this, in my mind, is these, when you read the National Transportation Safety Board analyses of how do airplanes crash, very often there are miscommunications that are driven by vertical power structures inside the cockpit. The captain is the captain, and the co-pilot is in some hierarchical power relationship that very often in these crashes, the co-pilot knew what was going wrong, and the pilot would not accept advice. Knowing that, and knowing that can kill people, that kind of power structure can kill people, I do just the opposite. I view my role as team leader is to create a permission structure where everybody on the team feels comfortable speaking up and saying, you know what, I didn't quite either, I thought I saw something else, or I understood it differently, or by the way, I saw this happen with the I'm very, very explicit about creating a permission structure for that. I'd have to talk to some old Navy guys, and I'd love to have a conversation with the Navy about command and control structures. I think the Navy has actually institutionalized this idea with the role of the so-called executive officer. Mm-hmm. The job of the executive officer is to tell the captain what they really think. And even if they are telling the captain that the captain is wrong, that is not interpreted as disloyalty. It is interpreted as sharing a common goal. And part of my way of doing that is by saying, geez, I don't know. I'm actually doing it to encourage other people to speak up. And there's one other thing that goes on that I've never talked to you about, which is if there is a question that I am pretty sure that some of our junior-most colleagues were not aware of, rather than demeaning them by turning and addressing to to some junior person and saying, by the way, are you aware that Instead, I direct it as a question to myself, and I'm hoping they're listening to the answer. So it becomes non-threatening and non-punitive and non-embarrassing.
So I wanted to thank you, Alan, Dr. Kantrowitz. I think that this was the whole goal of this was to really understand your mindset. I briefly talked about your accomplishments. My goal with the podcast is to get in your brain. And you can see by your habits, you can see by your efficiency, you can see their social connection as a team player. You are bringing other people up, whether it's playing music in the OR, grabbing their attention, whether it's saying, I don't know. You're bringing in that survival instinct where you feel fear, not only at times when you're doing surgery, you're also looking at your patients and saying that they're fearful. You're putting that yourself in their shoes. And you can see, what type of doctor you are. And there's no question, because you've operated on family members and patients of mine, that the type of neurosurgeon that you are is just not a title. It's just, you're just not a neurosurgeon. I identify you as more than that. And I really appreciate you taking the time to coming, speaking to the audience, describing in detail your life. And I appreciate it. Thank you so much.
Pleasure, Steve. Anytime.